Our next speaker is Dr. Mohammad Yaqub, Associate Professor of Computer Vision at MBZUAI. Dr. Yaqub specializes in AI machine learning and biomedical health and image analysis, and has published over 80 peer-reviewed articles, has 6 patents, and co-edited 2 books. He's also a much valued collaborator with the team here at ADIA Lab, for which we are deeply grateful. To tell us more about the medical multimodal mind building foundation models for health, please welcome Dr. Mohammad Yaqub.
Thank you. Thank you, Abdullah. Thank you very much for the introduction, and thank you for having me here at ADIA Lab and Abdullah. Before I start, let me just also ask you questions so I can get some information from you. And I see some familiar faces from MBZ University of AI, so probably you don't need to answer if you don't need to, because I know you. But how many research students are here? Or faculty? Or postdocs? Or how many clinicians? Oh, none. Okay. Oh, one. Okay. Right. It's just to help me like decide how exactly I should go through my talk. I didn't know who will be the audience, so I made it more for generic talk of foundation models. I'll try to also augment and add to the great talk that has been given by Professor Fu, and let's get started. So thank you for the introduction. So yes, I've been here for about 5 years at MBZUAI as an associate professor now, and working with a great team. This is not an up-to-date team list, but this is my team at MBZUAI, who's tirelessly working, hopefully, they're here, some of them here, tirelessly working on AI in healthcare problems, solving problems with AI, but also collaborating with the ecosystem in Abu Dhabi, UAE, and also outside the world. Because we want to solve problems, we want to really make it work. And as my fellow speaker, he mentioned that generalizability in AI is a major problem. I mean, there are so many tools that we build or solution, and if you take it to a different set of people or different ethnicities, it might fail. So before I speak about my talk today, let me just also tell you what I do. So many years ago, when I started doing research, I had 3 major questions in my brain that actually just doesn't make sense. So first question was, why do doctors end up diagnosing things very late? So Amal is here. She probably can tell you that endometriosis, the average diagnosis is 11 years for this condition, which affects a lot of women. 11 years. The lady will have symptoms for 11 years to get diagnosed. That's the first question. But the second question, even if the lady goes to the hospital or a person goes to the hospital, the diagnosis period is also very time consuming. And the third question that I was like puzzled about, then nobody can tell you the future. Nobody can tell you what might be the effect of, if I have, God forbid, a specific cancer and take some medication or chemotherapy, what's the likelihood of that should work on me or not? Currently, it's just trial and error. Healthcare is that. It's unfortunately. So my job as a researcher is to try to solve these questions and try to come up with AI-driven algorithms that can early detect, better diagnose, and predict the future in different healthcare problems. So in this slide, you can see like lots of images and videos. So I work on echocardiography. I work in I work in cardiovascular diseases. I work on fetal health, oncology-related problems, and neurodegenerative diseases, among other problems. But my talk today is a bit specific, and I'm not going to make it technical. I'll try to make it more of a general, because I see diverse set of people. But feel free to ask questions if you have a detailed technical question. So I'm going to start to convince you that we used to live in an era of single modality, trying to solve a problem with one type of data, but that's not good enough. Then I'll move on to the multimodal age that we're living in, what does it actually mean, and how we're trying to solve problems with foundation models. And then show you some cases where actually that's how doctors think. So we'll talk about like how actually things happen in hospitals. And then I'll show you 2 use cases, like two projects that I picked from my research, trying to solve that through building foundation models. But then I'll argue back that this is not the right way. Okay, so I'm telling you from now. So I'll show you some challenges and opportunities for foundation models. My team knows that we work in foundation models, but I don't believe in foundation models yet. So we'll do some argument at the end and a take-home message. So let's get started. Okay, so if you ask me, if I look at my research and anyone's research 15 years ago, or that happened just prior the era of deep learning, and which got reinvented in 2012, roughly. We used to do things differently. We used to feature engineer. We look at the data, we extract some features and try to solve and then feed it into a machine learning models. I'm going to talk about this initial revolution. Then with deep learning, we started to create what we call a single modality solution. So I have a problem, say I'm trying to solve reading or diagnosing chest X-ray to classify different diseases. So we just use chest X-ray and train an AI model that can read this data and diagnose the patient. So, but the input is only single modality. Although that was great, but doctors don't do that. They don't just look at one type of data to give you a decision. And hence, we lived for quite a long time in a separation that if you develop an algorithm or an AI solution or algorithm, you either work on images or vision data, or for some people who are not in this domain, like NLP people, they work on text data or other type of data, or genomics people just work on genomics. If you're a person working on just mining the data, looking at some patterns inside your data, then that gives you text only. So that's the separation we had. But with time, this has changed. So why was that wrong? Because doctors don't do that. If you go to a doctor today, for whatever reason, they're likely to ask you questions. They're likely to look at your history, look at lots of textual data, and maybe ask you to go for an X-ray scan or ultrasound or whatever. And then collectively, they will go through that data and give a decision. So in 10 years ago, when we were developing deep learning algorithm, machine learning algorithm to solve healthcare problems, we were doing it wrong because we're living in the single modality issue. Okay, so just to show you why this is wrong, because everything is siloed, everything is fragmented. We don't do it in summary as doctors do. So now then, let me just covered all of that. Yeah, then much more recently, we started to think roughly in 2020, oh, that shouldn't be the way we solve problems. The way we should be solving problems is to mimic doctors. Actually, the way to do it is to look at multiple data and work with it. And then we started to live in the era, probably about 5 years ago, of multimodal data. And just to convince you more, yeah, that's exactly, it's good to see you here. And as a doctor, you don't look at just one thing. You look at many things. And if you're diagnosing a patient, and you look at multiple things to make a decision. And this is hopefully a motivation for a researcher like me or anyone who's attending here to tell that to solve a problem in healthcare, the AI algorithm has to look at multiple things, not just one thing. Okay, so what sort of things I mentioned? As I mentioned, looking at electronic health records, multi-omics data, looking at radiomics, proteomics, or genomics, and many other omics data. And then I am a big fan of medical imaging. I'm more of a computer vision person, so this is the domain I work the most in. And then also there are many other data points that resides in a hospital settings where you can use it. But then 5 years ago, when we started to look into this problem, I remember some of my team here, the way we tried to solve it 5 years ago is, okay, take the images, try to have an AI model that can read the images and understand them. Take the electronic health record, try to also have a deep learning model or even small machine learning models that can understand the electronic health record data or any other type of data. And we created models 5 years ago that can somehow try to take the knowledge from all of this and make a decision. So a patient comes in, we take the chest X-ray, we encode it using an image encoder. We get some knowledge about that. Then we take the history of that patient as tabular data. We encode it with a usually simple algorithm or And then you get some representation, and then somehow we fuse them. And we lived 5 years ago in the era of fusing that. But we failed a lot because the clinician brain is different than like a computer algorithm that you're trying to fuse the data as just numbers. So we had to come up with a way, much better way, to make the healthcare data talk to each other. So a person comes in with a atelectasis or pneumonia on their chest. They get a chest X-ray. As if I am a doctor, I'm going to look at that. I'm going to look at the history. I'm going to look maybe on other things that maybe I'll ask him for a blood test or other type of test. But my brain doesn't just decode that as a set of numbers, and my brain perform reasoning. Get the data from here. What's the relationship between that number in the blood test with that location in the lungs, so that I can still see a little bit of effusion on that chest? So all of this goes into the brain of a clinician. And we failed to do that a few years back until we started to see foundation models. And here the idea is really that instead of living in a unimodal data, separate data, you create a way to jointly learn. You get the chest X-ray or MRI scan, you get electronic health record, genomics data, and have an AI algorithm that's smart enough to understand the relationship between them, not just a representation of a separate representation for each one. More of what we call for technical people, we call it joint representation. And then once you do that, your algorithm started to be smarter, started to understand context or relationship between this data. So that region on the MRI scan of the brain, for instance, might be related to that information coming from the history of that patient. So that's where the AI models or foundation models started to be very powerful, where they started to understand contextual and have a contextual understanding, which led us to what we call multimodal foundation model, MMFM for short. Okay, so that's my introduction to convince you that the steps what we've gone through. Maybe one more slide to just to summarize it before I go into really how they work. So prior 2012-ish, we lived in the handcrafted machine learning era. Then deep learning came to life, or revisited, or got reinvented. It hasn't been invented, it has been reinvented because it's been there. And then we started to create single modality models or single modality solution until much later on, in my opinion, a revolution of foundation model came to life. Okay? But it's important to highlight, it's not like every one of these steps is not like deleting what's happened before. In fact, it's building in what has happened before. In my PhD many years ago, I spent most of my PhD just try to do feature engineering to solve a medical problem. Try to understand and decode in the algorithm some features that the doctors can't think of. But then later on, we built on top of that, we came up with a way to stop doing feature engineering and have a much better approach to understand or extract patterns in the data. And then deep learning foundation models is this next step, which allows us to do even better in terms of understanding data from multiple sources. So in the previous talk, you've seen lots of applications, especially on retina, on understanding the diseases related to the eye and chest X-ray, on how foundation model could be very helpful. But I want you to understand one thing about foundation models. We claim they are really good as a generalist model. They understand everything. That's what we claim. So you train it on lots and lots of data, and then you perform what we call zero-shot analysis or zero-shot diagnosis. Take an example. If we go to hospitals in Abu Dhabi, collect all the brain MRI scans today, and we took all this huge data set, train a foundation model to understand brain diseases. It will do a good job in understanding some diseases, but it actually will not be able to perform well on rare diseases, as my colleague mentioned. But the reason we do that, the reason this happens, because we rely on the fact that we assume these models can do a great job as a zero-shot. What does that mean? Zero-shot means you train the model for a very long time on in different ways, but you then rely on the fact that it can perform well in many tasks without training on this task. So going back to my example, brain MRI scans, We train on this lots of data, but then we ask the model to classify if the patient has glioblastoma or not, or if this patient may have in future dementia as a predictor. It's never known, it's never been trained on that specific task, but we believe that this generalist model on brain MRI is good enough to do this zero shot. So zero shot assumption is very strong. It does work in some cases, it fails in many others. Here's an example. So you can train a foundation model on chest X-ray. We've seen lots of these from many research labs from all over the world, including myself. And then we assume, now it knows everything about chest X-ray. Let's ask a question. Is there a pneumonia or pneumothorax here? So because we are trained, usually we train it on images and text. So it's multimodal. And there must be some mention of pneumothorax at some point during the training. So we assume it learns how to connect the text information to the visual information. Not only that, then we can probably go to it. Yes, there is a pneumothorax. Where is it? And we ask it this question. Although we probably did not train it on data that has images and boxes to say, here's a pneumothorax. So that's the concept of zero shot that we target to do. So does that work? Now, in some cases it does if the task is simple, but in many cases this fails. I'm going to show you some examples later on. Okay, so in the coming few slides, I'm going to show you a couple of projects where we worked on as MBZUAI. There are also some posters outside from my team and also from my colleagues from other groups in my university. So have a look at them. But I'm going to mention two problems that the first one especially is dear to my heart, is fetal health. So I'm going to switch on a little bit into putting the clinical hat a little bit. I'm not a clinician, but this is a topic that I really like. Okay, let's ask you some question. Do you know how many child is born every year from all over the world? Rough guess? More than 100 million or less than 100 million? More? Okay. More than 200 million or less than 200 million? You're playing with me now. Yes, less. Approximately 150 million. I mean, there are different statistics. Let's say 150 million. Okay, that's not the question I really want to ask you. How many of them, unfortunately, end up with congenital problems, like medical problem during pregnancy? Approximately. 95%. You're very pessimistic. No, less than that. 5%. So in millions, let's talk millions. So how many, like a couple of millions? More or less? Around 6 millions. Every year, 6 million child is born with congenital problem. Obviously, there are many of them, many different types of problems. Could be brain-related, congenital, like heart-related, spina bifida, cleft lip. There are many different possible problems. That's why this is probably the most screening happening all over the world, where every woman, pregnant woman, goes for an ultrasound scan at least twice for a dating scan and anomaly scan. That's at 11-ish week and 20 weeks to verify if there is a problem or not, right? From these 6 million, every year, by the way, so it's repeated. From these 6 million, how many of them gets detected by our current technology and doctors, on average? So how good are doctors and not doctors? Doctors are great, but these are challenging problems. So what's the detection rate of these problems? On average, obviously, they vary from one condition to another. 2-3%. No, that's also very pessimistic. It's on average is 50%. On heart diseases alone, it's about also 50%. So 1.2 million child is born every year with heart disease. 50% is not detected. 50% is on average detected, which is shocking because if you don't detect it, you cannot do anything. If you detect, you can intervene. You can do an operation at day one, which has a much better consequences of not knowing about it. I mean, obviously, some heart diseases will be like ventricular septum defects, for instance. I mean, some patients or some kids their body will heal with time, but some won't. Okay. So what I'm trying to say is, this is just one example where we have a massive number of major problems all over the world, and I'm only talking about ladies who are fortunate to go to see a doctor and have an ultrasound scan. I'm not mentioning the 30% of the world population who cannot go to hospitals. Let's put that aside. But even if they go to hospitals, 50% to detect a problem, that's an average. So I worked on this problem for many, many years, actually starting from my PhD. So these are some stats I put here. I'm going to move on to tell you about something we wanted to do. But before I do that, here's some ultrasound images. You probably can guess what these ultrasound images are. Can you? What's the one on the top left? Now, obviously not the sonographer, or this is a fetal medicine consultant, Professor Iris Baba Georgia. So this image, what is that? This, yeah, right? What's this? Spine. What's that? Who said lips? I know. I know you're going to say that. That's a lip view. That's this view. That's the upper lip. That's important. If you don't do as a clinician or sonographer, don't check that view, you can't rule out cleft lip. You have to see this view. Some of these images are really hard to look at. I mean, I can convince you this is the lip because that's the upper lip. There are nostrils here. That's the lower lip and that's the chin. As a clinician, you have to see that. By the way, this is not hard to get. If you go to the heart, it's even much harder. Heart is like 1 centimeter squared on a moving fetus who's no bigger than this. And you have, as a clinician, to go to find the views of the heart, multiple views, 4-chamber view, 3-vessel view, and many, that's slicing the heart. And once you manage to get these views, you have to verify if there's a problem or not. This is a very challenging problem. That's why I don't blame doctors that they can't really find the problems in many cases. So what we did is, I worked on this many, I have probably the most number of publications on this one, but I will mention a couple of publications. First is in fetal clip, which is still under review. This is the foundation model that we built to hopefully work as a generalist model to solve fetal health related problems. We made it open source and anyone can access now and still under review, as I mentioned. And the idea is we collected lots of data from Abu Dhabi, from hospitals here, and we trained a model like that. We're still evaluating it further. And the idea is once you collect lots of ultrasound data in the top left, you create, we managed to develop an algorithm that can hopefully answer questions on these ultrasound data. So the way we trained it, similar to what you've mentioned, Dr. Fu, is most of us uses clip-based training. If you're technical, you know what that means. This is more of like an algorithm came in back 5 years ago from Microsoft that allows us to train a model that uses images and text to understand, to bring them together and understand the data from that. So if I have images, I can have a model that tries to sort of find the relationship between the image information and the textual information. That's a clip-based model, still very famous until now. They're more advanced version of that now, or not advanced, but more improvement on that. But it's still a very powerful based algorithm that can understand text and images in a good way. Then what we did, we tried to make it clinically guided. And what I mean by that, we looked at the data. We looked at many different things related to every image. So for instance, this image is probably this one, for instance, LVOT, left ventricular outflow tract. This is a view on the heart. This image could be something else, the fingers and so on. And we trained the model to understand all of this. Then we started testing it on different tasks. And then in a zero shot, obviously, but we also tried it on with fine tuning. And it turns out it does do a good job on different tasks, like fetal view classification. My first application on that 15 years ago, I couldn't do any machine learning algorithm that manages to exceed 80% accuracy. Now we can do it with 95+ accuracy. Also, biometry. This is very important to assess like how good is the baby is growing. So you assess the growth of the baby. So this algorithm allows you to do that. But then also we started to look at it to do much harder tasks. Like, can it tell me if the child has a congenital heart disease? So then we fine-tuned it slightly, and then it sort of manages to get an AUC of 80%. So that's the bottom right corner there, with fetal clip to diagnose the heart problem. Okay. But then Daria and other people, so Daria is here, and other people in the group, tried to take that further, and then focusing on fetal heart, and we used the fetal clip foundation model to further improve it, and then to diagnose fetal heart abnormalities. And I think the number we have is probably 80, an AUC of 85, or F1 actually, AUC is 88%, to detect congenital heart disease. This is not perfect. It's coming from mostly one major center, but now we're trying to evaluate with multi-center. Okay. So that's one good success story, but there's still lots to do. Let me tell you another success story, or starting to be a success story in my opinion. It's a recent project we started. And Nu'man is here, and there are other people working on it, Ahmed and also Daria, in echocardiography. So if a patient has a suspected problem with their heart, they go for ECG possibly, then probably follow-up of ultrasound. Ultrasound helps the doctor or cardiologist to assess the heart functionality. So they quantify many things from that. One of the most important biomarker they look at the moment is called ejection fraction. How good your heart is pumping blood. You want your heart is a pump. If it pumps the blood in a regular way, then you're good. Okay, so they do some computation of ejection fraction. And let me show you an example. So here's a 4-chamber view of the heart beating. And what the doctors do, they look at this view and try to quantify how much blood in your heart when your heart is contracted compared to how much blood in your heart when your heart is expanded. And they just a basic equation to compute ejection fraction. This is a classical way to do it. And there are so much research on this in developing AI algorithm to quantify that. And we started, but this is just one biomarker. There are many other biomarkers you can look at in the heart. And my team and I are looking into, and we looked at the literature. So the team has done a great job into benchmarking the majority of probably all foundation models built to solve a problem like this, how to quantify or measure if there is a problem in the human heart. This is a human heart, that's not fetus. Human heart. And we looked into multiple publications and we benchmarked them, and it turns out they can talk better than me on this. And if you can ask them, it sort of does work for some tasks, but all of them, in my opinion, all of them fail when things become more challenging. It means that they cannot perform a good diagnosis on the majority of the tasks. So what we did, we looked into some classification tasks, regression tasks, and we looked into how well all these foundation models created by Stanford University, a good colleague from Stanford University and other universities, and it turns out still fail because also if you test them on data from out of distribution, as my colleague mentioned, out of distribution is a major problem, they fail. So we're now working on really this is some result from when we did the benchmarking of these algorithm. I'm going to skip that, but to tell you, here there's a problem with foundation model. We say we're going to make them foundation, then we want to make them generalist. They can solve many problems in that task, in that domain. But in my experience, including the models we trained in my group, they're not generalists. We're far off behind to get a model that is as good as what we call a generalist on solving the problem. So let's talk about challenges in the last 5 minutes before I'm sure you're all eager to go to the lunch. Let's talk about challenges and possibly opportunities. So what are the challenges of foundation models? I mean, of course, data is a major problem. So the problem that if you want to solve a problem and make an algorithm that is like very smart, you really need to collect lots and lots of diverse data. If you don't do that, your model will unlikely work well, including models that we trained. We tried it on different data set because the size of the data we start from is small. So there are many problems. Let's start one by one. But honestly, I want to start by the regulation. So I worked in industry as well. So I have FDA approved medical device products, and that was a nightmare to get a product in a medical device product to be regulated with AI, to use AI. It took me back in the UK 6 years to do that, like from creating the project all the way to get it FDA approved to sell it. 6 years. For a startup, that's just a long time. It's a cash burning machine. But that's just At that time, it was not even a foundation model. It was a specific algorithm set of algorithms solving a specific problem. And to go to regulators and convince them to approve it, there's so many steps to do that. And now, if we now go to the era of foundation models, to regulate or to go to a regulator like FDA or DOH in Abu Dhabi, for instance, and tell them, I have a solution that solves this problem. It's a foundation model. It can do 1, 2, 3, 4. It's generalist model. We don't have any regulation on that yet. So we're far behind in terms of being able to actually see foundation models working in hospitals. It's probably going to take much longer than many people think. In my opinion, unlikely to see it in the coming 5 years. Just because in healthcare, you need to make sure things are going to the plan. So usually in regulation, you try to look at safety and efficacy. But to prove that for a model that you're claiming is generalist model, it's almost impossible for now. Another major problem we mentioned is data, but also it's very expensive to curate. It's very expensive to assess, although there are methods like unsupervised learning models that can hopefully mitigate that, but still a major problem. People are worried about job displacement. I'm not worried. We have a shortage of clinicians all over the world. So in the UK, where I was trained, there's one radiologist for every 33,000 people. We have shortage. We need more AI because there's so much shortage. We want to empower the radiologist or the clinician with AI. That's what we need to do. There's no replacement here. Yes, there might be a replacement where an AI autonomous car will replace a taxi driver. Yes, this will happen. But to replace a doctor or even any other stakeholder within the healthcare system, unlikely in the coming 20, 30 years, in my opinion, probably forever even. It's complex. Also, these models are usually huge, so they require lots of computation, and they're very complex. So to retrain them will be a major problem. In fact, we've recently started working on a topic called machine unlearning. Think of it this way. So you train an AI model on data, 1,000 patients. And if most of the regulators, they tell you the patient has the right to opt out of the study. So I already have like a model that has been trained on 1,000 data points. And at some point, someone comes from the patient, says, oh, take my data out of your model. How would you do that? So you have to either retrain the model from scratch, but you probably lost the original data, or you don't have the computational resources. You don't want to overspend on retraining. So machine learning hopefully mitigate that. But what if it's a foundation model? How would you unlearn data for a specific patient who doesn't want to continue on this study or this model? Unlearn this model, and you spend millions of dollars to train this model because it's very computationally complex, and you want to now to unlearn that data point. That's by itself a major problem we're facing at the moment. Obviously, security and privacy is another thing. So try to finish in a couple of minutes to allow a few minutes for questions, but there are lots of opportunities. With foundation models, yes, we started to see much better ways to allow multiple form of data points to talk to each other. Data coming from medical images, electronic health records, genomics, and more, that we can now have algorithms that can understand them. And that mimics a human brain when they make decisions, which will allow us to do many things. For instance, looking at this slide, you can obviously automate lots of tasks. You can allow multiple source of data, as I mentioned, but honestly, the most important thing, in my opinion, is to support clinical decision making. Okay, if you ask a radiologist today, would you rather an AI algorithm to diagnose this case for you or a problem, or maybe simplify your daily practice? Just maybe one example: sort your data points, like your scans, by their importance. That's more important than work hard for many years on developing a solution to diagnose brain cancer, because that's doable by doctors. But what's really challenging for them is get my job much easier. And that's what we're failing to do at the moment as a researcher and development, in fact. So yes, we want to improve diagnostic accuracy, but we want to do it in a way that is helping solve a problem rather than solve a problem that we make up. The final thing is, which is an interesting topic, is because now we can put lots of different type of data, we can accelerate research. An example I can give you, a study we're working on at the moment on multiple sclerosis. Multiple sclerosis doesn't have a cure. You need to manage it better. But could we do something with it? And we're now what we're doing. We collected all the papers, like many information about multiple sclerosis. Like imagine like there's 140,000 research papers on this topic. No one of us can read that and understand it. But what if you can have an AI model that can look at images, papers, books, the internet, and so on, and connects the dots, perform reasoning, which is also, foundation models are bad at reasoning still. But what I'm trying to say, now with this foundation model, it's really, there's a good way to improve on our discoveries. And that's what we're gonna see in the coming few years. Last slide, and I'll just be very quick. In my opinion, foundation models are great, but still bad. Bad in the sense they don't work well. They don't generalize, don't work in out of distribution as much as we really want them. It's going to change, but it may take quite a long time. So we're living in this domain of multimodal foundation model. I want to close on the point that my colleague also hinted to, is it's never been, we should never live in isolation between what AI is doing and what we human do. So human in the loop is a concept that we all should embrace and utilize, especially in healthcare, because it's augmenting what we're doing rather than replacing what we're doing. And with that, I'll finish up. Thank you. Sorry, you have...
For the great presentation. Yes, we have time for one or two questions.
Okay.
Hi. First, thank you for a great presentation. I actually come from a medical background rather than an AI background, but it was really interesting. So my question comes into the multi-model where you talk about the omics. So getting clinical data how would you think this would improve the model if we can get clinical data with the imaging and with, of course, the electronic health records? But what if we combine the multi-omics data by getting clinical information from patients? Would we be able to have better diagnostic and maybe even predict models that can predict biomarkers for early detection before the disease even develops, for example, if we combine all of these?
Of course, this is the current future, which is rather than working on data when a patient gets diagnosed, like or have major symptoms, many of us in the research domain work on early detection of diseases. An example I can give you, we have a study now with Burjeel, CCAD, and with SSMC here in Abu Dhabi. We're collecting for all patients who has breast cancer and colon cancer. The studies, we're going back in the history of these patients as long as we could and look at electronic health record, like lab results, for anything they've done in their life, hopefully, and then trying to develop algorithm that might be able to see things we don't see by eye to predict the future. So a patient who has breast cancer today, if we go back 3 years ago, and she might have, and I know you have lots of good work on looking at the fundus images, for instance, if you probably have to, for instance, multiple sclerosis or dementia, you can probably see damage on the optic nerve before even you can diagnose a dementia patient. And there's good research on that. So this is the future, which is going from reactive healthcare to proactive healthcare.
Thank you.
Any other question?
Myself also, I'm in a medical background, but interested in AI. But the thing is, when building models, health data is a big problem, irrespective of which field you are. Either you are clinically practicing or non-practicing. Especially in this part of the world, there is something called the health information system. For example, in the Northern Emirates, that's Rayati, Nabid, and Abu Dhabi, there is Malafi.
Yeah.
Why can't we use the health information system to boost this? If patients give
consent,
obviously. With the ethical.
That is the plan all over the UAE, and especially Abu Dhabi. The whole idea of Malafi, we worked on it. We had a ARB to work on a study on Malafi. At that time, it wasn't really doing a good job, but now it has significantly improved. The plan for Abu Dhabi, talking to people in the Department of Health, is to allow researcher, at least researcher,
True.
because also who's going to benefit from,
Yeah.
that's another question. Researcher to utilize Malafi
Yeah.
data to develop solutions to problems. So that's what Abu Dhabi is working actively on.
In addition, I mean, not only clinicians can use this data. For example,
Yes.
I come from a medical insurance background.
Mm.
In this part of the world, healthcare is not free; it is paid.
Yeah.
Okay, so who takes those risks when it comes? I mean, the future of health economics and insurance.
So that's an interesting one, because honestly, there's some resistance of sharing
True.
data
True.
to health insurance companies, because you don't want to utilize the data in the wrong way. For instance, if insurance company gets access to some data that they shouldn't, maybe this will affect the insurance premium for some people and so on. This is yes and no. This is correct and wrong in my opinion, because it will also delay how we optimize our insurance. I mean, if I tell you about insurance, I have big. I don't want to I want to be a bit diplomatic. Insurance is done in the wrong way so far here. And for instance, if I'm going to go see, I have a problem in my knee, why shall I go for a chest X-ray before I go for an MRI scan? But just because the insurance doesn't give you MRI scan approval unless you have a chest X-ray, which is not helpful. Which means in the data in the hospitals, there are lots of chest X-rays should not have been done,
Yeah, true.
and just because insurance mandate them. What I'm trying to say is, it's still going to take a few, Malafi and all of these great systems will be very helpful for researchers like us, will be helpful for universities, for advancing the technology, but it may take some time to convince regulators that actually also insurance should benefit
So
from that.
I mean, in AI we need this what you call like a multimodal thing. All sectors work together to come up with a solution so that humanity is benefited.
I completely agree.
Okay,
Thank you so much. Maybe we can continue the questions discussion over lunch. Thank you so much, Dr. Yaqub, for the great presentation. Thank you so much, Dr. Fu, for the great presentation. This will conclude the session B presentation. So now we have around 50 minutes before we reconvene back in the main room for the afternoon sessions. So it's time for lunch.